You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome, everyone. Gerard, that was a beautiful seizure you had. Beautiful.
Yeah.
I was so happy. I was looking up and watching that reaction on the webcam.
Well, because when you're playing the intro stuff, we can't hear it in the headset.
Right,
Because
right.
now we're separated by different states.
Right.
And so I'm like, all right, well, while that shit's going on, I'm sure he'll let us know when it's done playing. And I was just gonna say, hey, the reason I got this whole white background behind me right now is because I'm sitting on the futon and not in my chair, the futon. And then as soon as I started talking, all of a sudden I hear my fucking intro voice kick on because you completely just didn't let me know that was about to happen. And I got a little fragile.
Yep.
You know,
and then it was
my
no.
A little Italian response was oh.
Oh man, it was brilliant. It was great. I love watching those. When it was across the table, it was even better. But being 5 states away, this will have to do. So I want to welcome everyone back to the podcast, to the show. We are joined again with the Maha Butchie himself. How are you, Butch?
Okay, how you guys doing tonight?
Oh, just ducky. We didn't warn these guys. So typically when we record late, this show turns into a shit show and a half. At least that's how, historically it's been. And what are we recording at post 9 o'clock on the Eastern Seaboard? So yeah, it should be a lot of fun. For recording tonight, and
usually it's one of two ways. It's either like completely unhinged and we go down a fucking graveyard spiral, or we're all just so fucking tired and we're just completely lame, and everyone's like, yeah, okay, well, that was the show. Have fun, everybody. It was nice. See you later. Bye.
I honestly don't know if the show has ever been lame. I don't know if we can say that our show is lame ever.
You met us yet?
Exactly. That's what I'm saying.
We put up a few stinkers here, and then the first ones were fucking stinkers.
Oh, dude. Okay. with the first 5 or 6 out of the way, with it, those are like Rocky 5. They just don't exist. They're there. They exist, but no one really pays attention to them. Even though our first episode is like number 3 on the all-time listen list.
Yeah.
I don't know. That's probably why, our show hasn't caught on exponentially.
They don't get past those first couple.
Right, because they're like, let's start at the beginning instead of let's start at the current,
Right, let's start everything from the beginning. Well, first the earth cooled, and the dinosaurs came. It's like, no, just skip past that part. In fact, never show that part again, ever.
Right. That just didn't exist.
Well, that'd be now.
Right.
Let's go past this part.
So we have to, of course, welcome the Phil Foundation to the show today.
It'd be so great if we could actually hear the intro.
It's everyone should be doing this right now.
If only we had hair to headbang to.
I know.
This is true.
It's one of the things that I can't stand with using, and I don't understand why this doesn't work, but through the recording program and stuff that we do the webcam stuff through, I talk to you guys through the soundboard. Mm-hmm. And yet you can't hear the things that are playing on the soundboard. So it's kind of weird, but yet you hear other ones like sound bites. It's
only
really
some of
weird.
them.
Right.
I hear really bits and pieces of the music. That's
bits
it.
and pieces.
Yeah.
And the same
comes
thing
and
with
goes.
sound bites. Yeah.
It is definitely really bizarre how that works, but
That should be investigated.
it should be investigated.
Yeah.
Because
You're top men.
top.
Man.
Oh, I just watched that the other day. It was so good. So good.
I know. They've been doing I forget what the whole channel was doing. They were doing like a marathon of them.
Yeah. But yeah.
Which
So
brings me to the quick, just a quick observation. I know this has nothing to do with what we're supposed to do, but
sure thing. Go ahead.
As an Indiana Jones fan,
Yes.
I see the new one is coming out.
Yes.
And it appears to be taking place in World War II.
Yes.
Didn't the last one with the Crystal Skull take place post World War II?
Yes.
I believe so, yeah.
Hold on.
Hold on. What the fuck?
Hold on. Is it really taking place in?
Dude, he's jumping out of a okay, so now here's the airplane nerd geek fucker coming at me. They bail out of a fucking Heikel 111. It's a German fucking medium bomber. Yeah, it's World War II.
No, it's set in 1969.
And they're jumping out of a fucking World War II fucking German bomber?
I mean, I don't know.
Okay, I don't know. We'll figure it out.
Yeah,
I guess.
we'll figure it out. I just Googled it, but
I'm just so confused.
I know it's
Michael
Hollywood.
Keaton's coming back as
Don't
Batman.
try and make sense out of Hollywood. Just don't do it. It's not worth our time.
I know.
I know. But before we get to the call, I do have one announcement I guess a couple announcements to make. Kelsey is doing like Gerard did way back when, and she's going to be taking a sabbatical from the show. So I want to be the first one. Her and I talked in length the other day. She's having some high difficulty in scheduling, being this, settling into being a baby paramedic. So she's asked for some time away from the show. So we want to wish her the best of luck until she gets back, square where she can join us. Em was supposed to join us tonight, but then she ended up getting a call and having to go out and do actual like EMS shit. So that sucks. But so I guess for the time being,
she should have just done nurse shit.
Huh?
She should have just done nurse shit.
I know, right? But I guess until Kelsey comes back, unless Phil wants to take it over in future episodes, I will be the one doing the rig checks since we haven't been doing them because I've been giving them to Kelsey for so long that it's just kind of her thing.
If you give them to Phil, it'd be like giving them to Kelly. So.
Right?
that's how much he talks.
I think Kelly talks more.
I think
probably.
Kelly
I think
does
so
talk more. So let me get into the rig check here, and then we'll start on this show. So this week only, after this show is going live, Medic Materials is having a flash sale, 20% off of all the podcast episode CMEs that are currently available on the Medic Materials CME Academy. So if you're interested to get that code, go to medicmaterials.thinkific.com. Use promo code Donuts20 at checkout. This offer is going to be good until Sunday, February 19th. So again, make sure that if you want the CME credit for listening to this show or any of the other podcasts, hit the link in the show notes. Head on over to the CME Academy. Use Donuts20, and you get some money off. Also, I am asking you guys to join the members of the podcast like myself, Gerard, Emily, Mr. Phil, the Maha Butchie, on the new weekly Friday live stream called End of Tour. This is a place where we get together, hang out with fans of the show, decompress, and just enjoy the time with friends after a very long week of EMS work. So catch it every Friday night, 9 p.m. Eastern on the Medic Materials Facebook page, Facebook group, and the Medic Materials YouTube channel. Before we get to our official shout-outs for this episode, I want to thank our absolute loyal fans. You guys are doing an amazing job with pushing us over the top. We've just crested the 16,000 download mark for this show.
Wow.
And I just want to, say thank you, a humble thank you to everyone who supports this show, listens each and every, 2 weeks that we, put out a new episode. But I want to encourage everyone, to follow, rate the podcast on whichever platform you guys use, as well as share this show out with everyone that you know that's in the EMS realm. The grassroots ability for this message to spread is solely dependent on you guys, our absolutely amazing listeners. And finally, we want to shout out our listeners in Portugal and Michigan. So thank you for listening each and every month.
Wow.
Yeah, so the show is growing. And
Dude, that's like a hockey arena full of people.
Yeah, it's bonkers. It really is bonkers when you think about how many people listen to this show. And, I don't advertise this show. Like, I really don't.
Well, maybe you should.
Well, no. I'm saying like in the realm of like spanning, or not spanning.
Yeah, I know.
I'll hit my buzzer on that one. I'm saying like I don't spam this show like other EMS podcasts. I'm in a group, EMS podcasts on Facebook. That's a private group. I share the show there. And then I share the show via my own page, the medic materials page, and then whatever you guys share. And that's it. Like,
Yeah,
I would just go shameless.
Yeah, I don't go to, paramedics of Facebook and share it there, or, like drinking bros or any of those, because every time that I've tried to do it in the past, they take it down and they say, this isn't the appropriate place for this. So
well,
I just
you're not
stopped.
one of their dude bros.
Exactly. So I just stopped. There's other podcasts that get to do it.
Right, because they're the dude bro.
Right, but not us. So I just said, well, fuck it. I don't care, So it really is up to the listeners of this show to push us over the top. If you're really good with your partner on, Friday night or Saturday night, whenever you're doing your shift, put it on the ambulance radio. Make a fan out of them. Share it. There's listen parties in some hospitals around here where like 10 nurses.
That's wild.
Yeah, 10 nurses listen to us all at once in the middle of the ER, which is probably the most inappropriate thing ever.
No, it's perfectly appropriate. Keep doing it. That's what we want.
It is what we want. The things that we say on the show is inappropriate. That's what I'm saying.
To a certain extent.
It's all right.
Yeah, it is what it is. But so without further ado, let's dive into this call. It is an interesting one, just like all of our calls.
More ado.
Yeah. So your system. This call takes place rural EMS district, covered by a volunteer ambulance company, which does the like hybrid thing where they pay EMTs from a different agency to staff their ambulances during like banker hours. And so the rig today is going to be staffed with 2 paid EMT basics. Now the district gets most of its ALS coverage by a commercial private ambulance that locates one of their trucks in a local firehouse on the outskirts of the district. So they're not actually within the district. And this commercial ambulance is staffed with a paid EMT, EMT basic, and 1 paid paramedician. You guys have 2 hospitals in the area. One is a level 2 trauma center located in a small city approximately 30 minutes north of the district. And you have 1 cardiac/pediatric hospital located approximately 40 minutes southeast of the district. So your hospitals are in opposite directions, about equidistant in time. You guys are going to be dispatched to a Charlie priority 2, to a private residence for a 59-year-old female with shortness of breath. So just as I always take the time to ask you guys, what are you thinking, blah, blah, blah. But I'm going to switch it up for shits and giggles here. And without any other information, I want each of your guesses to the cause of the shortness of breath. Go. Gerard, what's it going to be?
Carbon monoxide.
Ooh, that's a good one. We've not done one of those, but that's a good one. I like it. All right, Phil Foundation, what's yours?
PE.
Heave?
PE.
Oh, PE.
Oh.
I heard
I was like-
heave
I was like,
like
during the
he's gonna
Ukraine?
All right. So we got PE, we got CO. What's yours, Mr. Mahabuchi?
Give me the one that starts with 2 letters.
You just talked over the Mahabuchi.
Well, you know me. I'm always going cardiac. So there we go.
All right. So you
Forgive me, Mabuchi. I do not have your superior intellect. and education.
But could it be?
So the BLS crew arrives at the home. They gather their first in bag and begin to walk up to the front door. At the door, they find that the door is slightly cracked open, and after peering inside the door, they see a female sitting in the living room in a chair near the door.
Are they peering like Scooby-Doo peering through a door kind of thing? Or
Are they leering?
I mean,
are we leering?
They're not doing one of these. They're kind of just doing one of these, like, if that makes sense.
Like awkwardly staring? Okay.
Yeah, they're peering through the door. Like, there's a crack in the door. They're just kind of looking through it. All right?
Okay. Like Telltale Heart kind of peering. Okay. Good.
Yeah. So the crew announce their presence and go ahead and enter the home. The female tracks them through the room as they walk towards her. She appears to be breathing fast with notable uses of her neck muscles on inhalation, is pale and diaphoretic. So
good.
We're already gathering all of this like really good data and much needed details, but like I heard like, oh God, not good. Is that kind of the consensus for your guys' feeling of this initial look test? Like, this could not be going where I want it to?
Yeah.
Yeah.
It sounds like it looks like respiratory failure.
Right. It does not sound good in the slightest. So the primary EMT approaches her, they introduce themselves, and they ask like the whole what's been going on question. She's able to answer them in broken sentences, taking frequent breaths to breathe very deeply, like the full sucking in of air. They take this as her airways open. It's clear. They don't see any like debris or fluid around her mouth. The breathing appears tachypnic, very labored, but equal in chest rise. Peripheral pulses, they're taken. They're very weak, almost unpalpable, but present. She goes on to tell them through these broken sentences, so it takes a little bit of time to get all this out. But she goes on to tell them that she's been feeling run down with flu-like symptoms for the last 5 or so days. She went to urgent care 2 days ago, but she did not come back with any test results that confirmed any illnesses. So they gave her a neb treatment and sent her back home. She goes on to tell them that she feels like she can no longer breathe, is exhausted, and having trouble staying awake, needing to be seen at the hospital. So we just got a plethora of like history here, like history of present illness. What do you guys make of that information, and how do we proceed forward in here?
So do we have any initial, like, can they hear any adventitious lung sounds from just standing here? Do we have that information?
Not yet.
Okay. You know, because sometimes you can hear that from the door. You're like, that's bad.
Yeah.
Did the neb treatment work?
Apparently not.
Okay.
Yeah, apparently not. It almost sounds like, you know, the urgent care kind of blew her off and was like, yep, we didn't find any source of infection or anything like that. See you later. Goodbye. You know?
Well, just based on what she looks like before I continue to talk to her, I think maybe a little O2 would be in order. So maybe have EMT start doing that. And yeah, I'd like to get a little more history, like, you know, what kind of medical issues do we have?
Right.
What skill level are these EMTs? Like, are they CPAP trained or are they just O2 trained?
So these guys are O2 trained, not CPAP trained.
Right.
Okay. That is a good thought process to start getting into, right? So
I've been there. I told an EMT before, hey, it was kind of a system like that where it was only was volunteer ambulance, and Yeah, and I'm on scene, and I'm like, hey, okay, let's get the CPAP going. They're like, okay, and they come back with it, and they set it down. I'm like, well, let's get it going, and they're like, yeah, we don't know how to do that.
Yeah, that's a you job.
I'm like, but you carry it. Yeah,
Yeah,
we do.
it's for show. It makes us look good. So the primary EMT instructs their partner to get a baseline set of vitals while they go and like see, hey, patient, where are your meds, right? They know that they can't get something out of this lady because they don't want her to talk a lot. So they're going to go and try and find history through the meds. So they're pointed towards the back bedroom where they go and find 4 pill bottles. A pill bottle
That's
for,
it?
yep, 4 pill bottles. A pill bottle for Lasix, metoprolol, lisinopril, and glyburide.
Ooh.
When
No
the
clue.
when the primary EMT arrives back in the living room, their partner reported a manual blood pressure of 136/72, a heart rate of 92, but very, very weak still, respiratory rate of 36, very labored, and a pulse ox on room air of 82%. It's also noted that the patient has no known allergies to anything. So, is there a specific way that with this further information, you guys are looking to fix this lady's oxygen sats at this point in time?
Well, first I want to know, are we listening to lung sounds?
They did not listen to lung sounds yet.
So you have a respiratory patient, you're not listening to lung sounds?
Not yet. Give me 2
Okay.
paragraphs and you'll get
Okay.
that.
It shouldn't be 2 paragraphs in. It should be in like the first 3 sentences.
I
Walk in door, patient's white, tugging, freaking, oh my God, I'm going to die. Hey, quick, throw her on O's and let's listen to the lung sounds.
I don't
Done.
disagree with you. I think you're 100% right there. Like, Macho Man agrees, but it's still 2 paragraphs from now.
And anybody check the fridge for other medications
Nope.
like they've taught them to since day 1 of EMT class?
She kind of points them in the direction of where her meds are. So it wasn't like they just started rooting around the house. Like she said, they're that way. Go and find them.
How full is the Lasix pill bottle?
I couldn't tell you. I didn't ask the providers that.
So aside from
Who
the,
knows? But
if
good
we
question.
discount the vitals, I would start suspecting that we definitely have a blood pressure possibly leading to possible CHF.
Okay.
Because of, I mean, you've got you've got it all in there. You've got the Lasix, you've got the you've got the lisinopril and all the good stuff in there. So I mean,
Yeah, but you got the glyburide though, so we could be pointing towards some DKA going on here.
Yep. I like where the conversations are going, right? It's not solely respiratory at this point. We might have some issues with sugar. There could be other issues that we still haven't figured out, right? So the primary EMT tells their partner to go ahead, start getting stuff ready for extrication, because they just want to scoop and get going. During that point in time, while the secondary EMT goes and gets all the stuff for extrication, the primary EMT places her on 12 liters oxygen via non-rebreather, and then attempts to get a further, physical exam. They finally get lung sounds. They find that the lungs have coarse crackles with scattered wheezing in all fields bilaterally. Ventilations are still very fast, but they're regular. There's noted to be significant use of accessory muscles, including intercostals, the neck muscles with some neck turgor. And then lastly, they notice some heavy pitting edema, which is non-weeping to both lower extremities. She's still alert and oriented ×4, but becoming more anxious and tired with her eyes beginning to now close. So anything to say there, or should I keep reading?
Unless we're going to do a rapid intervention right now, then I would say continue to read.
Okay, so the secondary EMT comes back into the room with the stair chair to extricate her from the house. The EMTs assist her to a standing position, pivot her onto the chair, then move her out of the home and to the stretcher, which is waiting outside of the house. They place her in the ambulance with no issue and begin to recheck vital signs. Most importantly, they go for the pulse ox probe, which they note that the pulse ox has decreased to 78% from that, 86% that it was, or 82% that it just was. Still on the 12 liters oxygen via the non-rebreather. It's at this time that the EMT looks at their partner and goes, hey, where's that paramagician? It's like, we kind of need them. And their partner goes up front, calls dispatch to find, the ETA to the paramagician, to which they're told that no medic was placed on this call. However, one will now be dispatched. So,
nice. Well, thank you very much.
That's useful.
Right? It's so useful. So we have a patient that's clearly declining, right? We have dispatch who's completely dropped the ball.
Where's that chopper?
Right. Like they've left this EMT to fend for themselves, more or less. So what do these EMTs need to do at this point? Like, they're kind of left, hanging out to dry.
Do they have access to the CPAP equipment?
No, they are non-CPAP trained.
Okay. Do they have access to the CPAP equipment?
No, it's not on the rig.
Okay.
No.
Because, like I said, the ones I had, they weren't trained, but they had the shit.
Right.
So,
right.
I was going to suggest that, hey, you know what? All bets are off. You may not have been trained, but I'm pretty sure you've seen it done. You know how it works.
Orientation by fire. Here we go.
It's not fucking rocket science.
Right.
You know what I mean?
At least, in like, not cowboy it, but call a doc and be like, hey, doc, I have this. Walk me through it. Even.
Yeah, you can do that.
This way you don't Yahoo it and get your card taken away.
Well,
What's her mental status?
Declining. She's getting more and more tired, more and more anxious.
Bagger.
Yeah. Assist her ventilations, pop her up to 30 degrees, get some sort of positive pressure. Go ahead.
I think that's where if they don't have the CPAP and her mental status is declining, I think that's their only route. Like, that's their only option here.
And start driving towards wherever that medic's coming from.
Yeah. Now, are you guys going to transport to the 30-minute away hospital or the 40-minute away cardiac center?
As an EMT basic?
Yeah, so let's see.
I'm going to the closest one.
Closest.
Yeah, so there's a level 2 trauma center that's 30 minutes and a cardiac ped hospital that's 40 minutes.
30 minutes?
30 minutes.
Yeah, 30 minutes.
Okay.
Yeah.
All right. So these guys, they end up doing a priority transport, lights and sirens, and they end up going to the cardiac hospital 40 minutes away. That's their decision.
Which way, in which direction is the paramedic?
Is the paramedic?
Yeah.
The paramedic that covers the district is closer to the trauma hospital. They're
going the opposite way.
Direction of the paramedic. Correct.
Oh, okay. So they're actually going the opposite way.
Right.
Okay.
They're going, instead of going.
Then that's that's a fumble.
Yeah. So instead of going north towards the closer hospital and the paramedic, they're going southeast away from the paramedic and away, like a further, distance to the ER. So
the sphincter check failed and they went the wrong way.
They went the wrong way.
Okay.
Because they haven't done anything like, oxygenation wise to fix the problem other than non-rebreather oxygen too.
So to fix the problem, we're going to not go towards the paramedic and we're not going to go towards the nearest hospital because, God damn it, we want to kill this woman.
We just want to drive fast and we move on.
You suck, jackass.
Right. Like, I don't know.
I am trying to
I don't know if they
formulated a
thought,
guess in my head.
I don't know. Maybe they thought that this was cardiac in nature and they wanted
Right.
to go to the cardiac facility. That's the only thing that I could think.
That's all I'm coming up with, dude.
Right. So
It's-
But I mean, most hospitals could handle CHF.
exactly.
Agreed.
It's not like it's a specialty thing that only a cardiac center can handle.
agreed.
Right, and if it's a level 2 trauma, I mean, I'm fairly certain they've got RT on premises.
Yes. Yeah.
Mhm.
I mean, your local, podunk Band-Aid station has RT.
And they can handle the cardiac problem and ship it out when it's stabilized. I mean, that's
Exactly.
not an issue.
Right. So they end up transporting to this cardiac hospital 40 minutes away. They're told, by dispatch that their paramedics is coming from, now behind them. Whereas if you turned around, it would be in front of you.
Slow down.
And, I must say, as good EMTs would do, they don't wait for the medic. They just start hoofing to this hospital.
Dude, they're like the fucking football player that catches the ball and runs to their own fucking end zone.
I'm not saying it was the most
You know,
brilliant thing to do.
It's like, hey, you made the catch, but
I'm not saying it was brilliant. But what they end up doing is they tell their county dispatchers, cancel the first medic and dispatch a second medic from now going southeast.
okay, so our heads are not totally
Right.
inverted to our rectum, so that's pretty good.
Right. So they end up getting an out-of-county ALS fly car unit to respond as their intercept. They're going to intercept with them approximately 10 minutes down the road. So not so terrible.
Okay.
So transport begins. Primary EMT increases her oxygen via the non-rebreather to 15 liters from 12, then takes a second set of vital signs.
No bagging?
No bagging yet. They're still on mask oxygen. All right. So originally,
It's going to make a big difference.
I 100% agree. No. I'm with you. They're doing what all all non-looking at the big picture EMTs do, which is, they're half lethargic and they're, shallow breathing and boom, face mask oxygen. Like boom.
Boom, boom. Boom.
So that reminds me now. Oh no, that's BAM. Never mind. I was thinking, I should get the Emerald, boom, but he did BAM. Never mind.
No. You're
So-
confusing Emerald with John.
I'm mad.
Boom.
I don't
Boom.
know. I don't know.
Boom.
You know what? I might be able to find that actually.
If you can, it's a problem.
It's finding a clean version that's, a good enough soundbite. That's the problem. So transport begins. They switch over to that, 15 liters. Then they go and get a second set of vitals. Originally, they had been using.
I'm sorry. There's a weird little delay, and I could have sworn you were about to say we went and got a second opinion.
Hey, Doc, am I killing this lady fast enough for you?
Right? So originally they had been using the right arm for blood pressures. This time, the EMT attempts the left arm and finds what the EMT believes to be a dialysis port on the left arm. So, okay. I saw a lot of terrible faces that people can't see. So I'm going to pause here and investigate Butch's terrible face.
I'm just going to close my laptop. Please, now.
Lay out in the backyard and die.
Yeah.
So
Okay. Disclaimer now. It's bad to do blood pressures on a dialysis port arm. Okay, I'm just going to put that out there.
agreed. Yep.
All right. Just going to put it out there.
Yep. Now, granted, they haven't actually done the blood pressure on that arm. They want to, and then they see this dialysis port on this left arm. So by this point in time in the call, the patient's mental status has declined from being alert and oriented to being responsive to verbal stimuli only.
There goes that CPAP.
And when she does respond, it's very few, very quiet words. And they end up like saying, hey, is this, thing on your left arm for dialysis? Which she slowly responds, yes, and then nods off again.
Is it called
I
pre-death?
ask.
So,
Who cares at this point? Just fucking breathe for the goddamn lady.
right?
This is called pre-death.
Yeah.
Ma'am, I'm sorry. You're not going to be needing this where you're going. I just want to make sure everything's all squared away.
Yeah. I just want to know if I can actually do a blood pressure over here or not. That's where they're going. So the cuff is moved back to the right arm and vitals are rechecked. Blood pressure is 102/54. Heart rate of 86 in regular, but peripheral pulses are now no longer present.
Oh, good.
Carotid pulses are present. Respiratory rate of 26, becoming more shallow. SpO2 has fallen on the 15 liters from 70 something to, or 80. No, it was 82. Now it's down to 76.
All you had to do was bag.
So,
All you had to do was bag.
So,
if you crank that little tree up a little bit, you get like 25. It may help a little bit,
Yeah. Well, Hey, you know what? If you put a cannula on too, that might help too.
Yeah.
If you take the end of the oxygen tubing and just breathe into it really hard.
I mean, personally, I think this person should just do bihemispheric
oxygenation.
That's better day. At this point, why not?
I mean, at this point,
take a towel out and wave it at her, give her some fresh air. I don't know.
No. That would involve you actually doing something. So we want to do as least as possible. So we just want to stick a cannula in their ass, not a reader on the mouth, bihemispheric oxygenation.
Yep. And
shake her once in a while to make her responsive. I don't know.
Yeah.
Ask her stupid questions along the way to keep her awake.
Yeah.
Turn the vent in the ambulance all the way on. Turn the fans towards her and sit in the captain's chair and do your chart. That's about all anyone's gonna do.
Honestly, I don't even think they're charting at this point. I think they're taking it one step further and popping the top to a frothy Stone Cold Steve Austin. Broken skull IPA. I think that's what they're doing.
Give her some milk.
I was just gonna say they didn't try the milk.
They didn't try the milk. Oh man, that's phenomenal.
If the cops are there, we give her some Narcan, because clearly she's not breathing properly. So
clearly not.
Yeah.
So the EMT does what we all hope they would, and they take them off the non-rebreather, and they drop an NPA flawlessly, and begin to ventilate the patient with the BVM. Finally.
Is this serious?
So now this is what kind of, I don't know,
makes you mad? Peeves
well,
you?
It's one of these things where I don't know anything about these EMTs. I'm just going to assume that they are not veterans. I'm just going to assume that, and by veterans I mean 15 years, 10 years, 20 years, that kind of shit. I'm assuming these guys are probably within 5 years, let's just say. And even though I would hope within 5 years they would fucking understand how to do shit better by then, but
you never know.
This is where EMTs being trained about bagging, it's so fucking deficient, it's not even funny. Because I guarantee you they probably either didn't have any idea that you could, or didn't have any idea how to bag a conscious live person.
Or, I'll throw another or in there, or they don't know how to bag in general, like when to utilize it. Because that's the other big thing that I see a lot in the EMT classes is, you can't bag conscious people. That's mask oxygen. Automatically, you have to be unresponsive, not breathing, and be on the floor for you to
That's the criteria.
Right. That is the criteria. Yeah. And that's the stuff that I'm trying to change literally in the EMT classes.
Yeah.
Because that's the mentality. And that's what's scary about it. So they finally start BVM oxygenation, and they do this until for the next couple minutes until they finally intercept with that paramedic fly car.
Did we get an increase in sats at all?
I will get there. Okay. So the medic gets into the truck and they have their cardiac monitor, their drug bag. They're brought up to speed by the primary EMT and given the last set of vitals. Now, since the start of the assisted ventilations, the oxygen sats have gone from 76 to 89 on the BVM.
Would you look at that?
Amazing, right? The medic connects her to the cardiac monitor and EKG. Initial rhythm is what appears to be a sinus with a large peak T wave, at least 4 to 5 millimeters in elevation. The medic gets back out of the rig, gets their airway bag from their truck, and then transport begins. Again, now they're heading towards the cardiac facility again, but now they're a half hour away, right? They cut that initial 10 minutes off. So in your guys' opinion, a paramedic's present. We got a little bit more ALSE information here with EKGs and stuff. SATs are improving. What's on their immediate to-do list?
Get a 12 lead going. I think that would be before we would leave. Get a 12 lead.
Yep, I agree.
Let's get a blood sugar.
Okay. They eventually do one of those. Yep.
End title would be nice.
Okay. I will say end title comes way later, but it is eventually done.
Nice.
Yep.
And of course, IV, O2, all that good shit.
Yep. I think that, right.
They two at this time, yeah.
So at this point, are you guys in a camp at all for what is causing all of this stuff? Like, how are they going to treat this shortness of breath?
Well, we're at that point of, really altered right now. So CPAP is going to be, out the window at this point, because of the altered mental status.
I mean, maybe consider a nasal tube.
Okay.
She's still
breathing.
She's still breathing on her own, so it's not, she's not stable enough for an RSI by any means.
Yep.
But
I would definitely set up for the intubation because it looks like we're heading this way with a half hour to transport. I would be ready for that.
Yep.
Yeah, I would get the respiratory drugs on board, blow a neb through it. Just to do what we normally do for, assuming of course the 12 lead doesn't show a fucking MI.
Right.
But assuming it doesn't show an MI, we have sounds in hand.
Yep.
Out of the lungs, so start treating that and try and dry some of that up, blow some of that shit out, get rid of some of the inflammation if we can, and and then honestly, if it was me, I may just go ahead and slap a pair of pads on her just to be safe.
I mean, it's
just get everything else out and ready.
I would get ready for a code. Yeah, I would just start. I'm not going to say, hey, we're going to get a code. I'm just going to slowly just maybe pull some things out, set them down on the bench just in case, so I can have quick access to them.
Yeah,
and maybe throw a second line in while we're rolling.
Yeah, I think being prepared for everything that is going to happen in the next half hour is where your success is. What this paramedic does and doesn't do, I will forewarn you, there will be a lot of yelling in approximately 2 paragraphs.
Go as in.
All right.
We clarify. As in peaked T waves, are we talking like hyper K? Or are we talking like demi peak T waves? What are we talking about here?
The only thing that I can tell you about the T waves is they are large T waves. They're peaked at least 4 to 5 millimeters to the middle of elevation, if that helps. All right.
Does he give her the milk?
He does not give her the milk.
Damn. Does he slam her with 2 liters of fluid?
Nope. Just wait.
Oh, God.
So,
I would love to see the 12 lead on this right now, but hey, I have to sit here and be. Okay,
Mr. Butchie, I would have loved to have seen the 12 lead
Mister.
here.
Oh yeah,
Mister.
Yeah, Mister.
Wow.
So
he went to Maha school. He's
so
he's not Mister.
If you didn't catch that because you were thinking about the Mister and the Mahas, I would have loved to have seen the 12 lead, which means I didn't see a 12 lead, which means they never fucking did one.
Oh my God.
Wow.
I'm gonna go to bed now. See you later, bye.
All right. Well, shouldn't this be a Patreon?
You know,
Are we gonna say bad, nasty things here in a minute? Probably.
Yes. I
let's
wrote.
just hit the checklist real quick.
Okay, checklist.
Will there be a wet bandage?
No.
Will there be a UTI?
No.
Do they check a blood sugar?
Yes.
Okay. All right. So hey, 1 out of 3 ain't bad.
1 out of 3 ain't bad. Just wait.
It's kind of like the brains of a girl.
They don't give it the milk though.
All right.
They don't give it the milk.
So, the medic obtains a next set of vital signs. All right. Blood pressure via the NIBP cuff comes back as 95/51. So we've gone from
We have trended down.
right 136 systolic to 95 now. Heart rate of 89, still sinus with those peak T's. So that's gone from 90s to 89s. Respiratory rate of 24, still shallow. Remember, that was in the 36, 35 range when they first started.
And honestly, if it wasn't for hermatoprolol, would have had a tachycardic heart rate to begin with. So
Right, exactly.
you know,
Yeah, we would have been
She
kicked
can't compensate.
Right.
Right.
They would have found her in the 130s. Absolutely. So SpO2 via the BVM is now 91%. They do start an IV line successfully. 18 gauge to the left AC.
Oh, wasn't it 22 in the hand?
Nope,
Right.
wasn't 22
Wow.
in the hand.
24 in the scalp.
A blood
It's the
glucose.
lysis in the sub Q, you know, like
Right. Yeah. You know.
The blood glucose is finally obtained. However, it's obtained off of the IV cath, which I personally fucking hate. But
course it is.
they get it, and it comes back as 185 milligrams per deciliter.
so
They-
it's probably about 210 for real. But you know, hey,
Right.
Whatever. All right.
It's up there, right? It's hyperglycemic. They give
Yeah, but it's not like holy fucking Jesus hyperglycemia.
right. It's not 7,000.
pluribus unus, dominus
Agreed.
unus.
Right. It's a pluribus.
So
Yeah. We're not there yet.
Decadron's given via the IV,
Nice.
and a duoneb albuterol atrovent treatment is given and bagged through the BVM.
Nice.
So not terrible. Okay. However,
Okay.
it's okay. Here's
Not great.
Here's
Not great.
where I want you guys to not kill me. Don't hit things. Don't break arms. All right. But
You say this motherfucker breaks out the adenosine, I'll fucking kill you.
nope. This guy.
The atropine.
This guy.
Guy,
This guy.
Goes and says, all right, this girl's got a steadily declining mental status, the presence of very significant difficulty breathing with no change from the medications. I'm going to prep for RSI. Now, stand by. This system allows for
provider
one
RSI.
provider RSI.
Oh my fucking god.
Fuck.
So,
Well, that, ladies and gentlemen, is the end of the show.
Dude, they get the corner to there right away, or
Hope you enjoyed the veal.
wow. Oh my
Oh
god.
my god.
Oh fuck.
So
Oh my god.
No. We're completely
Yeah,
fucked.
we're
Completely fucked. We're completely.
So what
Yes,
do you
we are.
what do you guys feel about that?
One, there should be no system that allows single provider RSI. Number one.
I'm with you there.
So,
This is how people die in a hurry.
well, she was dying too.
Yes, I mean she was dying.
Just not in a hurry.
without-
Now she's going to be dying in a hurry.
right. Now
We're just going to speed the process up.
you guys are you are 100% correct, Gerard, when this should be a Patreon episode. However, I
Yeah.
want people to understand what we talk about on Patreon. So this is my shameless plug to go become a Patreon subscriber to hear calls like this every single fucking month.
So I'm going to play devil's advocate.
Okay.
All right. I'm going to put my devil mask on.
I like where this is going.
Ooh.
Okay. And I'm thinking to myself, because not that I have done this, and I'm not even joking. Like, I have never even considered doing anything like this. But I know me, and I know if my ass was against the wall, and I think I'm going to lose her if I don't get her intubated. And I am confident in my black magic. I might try a balancing act with pressers. Get her pressure up and then fucking tube her.
But see, I'm not against that. I'm still with Phil in why can't we nasally intubate this lady?
Well, that's just it. We could do that. But I'm like I said, devil's advocate. If I'm in there and all I'm thinking about is RSI, the only way I could really do it with any hope of not killing her is to bang her fucking BP up.
Right.
So that way when it tanks, it don't tank to the point. But then again, I'm going to bang that pressure up. Now I'm going to have a fucking increased breathing problem. So
right.
It's like,
now here's the other thing.
This is me with my devil mask on.
Mm-hmm.
So,
let's say she was stable enough for an RSI. Are they going to use the etomidate sucks even with her possible peak T waves?
Of course they are.
Why you were even asking? Of course they are.
I know they're going to, but I'm just saying. I'm opening the door for conversation.
Can you hold off on that conversation until I get to the sentence which is
where they use etomidate and sucks?
Which, because we know what idiot paramedics do, they choose etomidate and sucks. It's literally three sentences away.
The old man in the room here used to be back in the day when we didn't have the old RSI. We used to have the old MFI where you just, the etomidate, a little bit of Versed.
Yep.
That was the way you did it. I mean,
the first place I was at, we had MFI, and in fact, even after I became paramedic, we were still doing MFIs, and it was you push one,
brutal, but that's what we did.
Yeah, you push the sedative, you try to go in, it don't work, you come back out, push the paralytic, more sedative, go back in. I mean, it's
not a paralytic, it's just etomidate's not a paralytic, it's more of a.
No, I know what it is. I'm just saying where I was at, it was a
poor man's RSI is what they call it. Yeah.
Yeah.
It's still in the protocol, but it's
let's just say they would push a sedative, and then we would make an attempt. If we didn't get it, we'd come back out, push more sedative, and then push the paralytic. Either sucks, or I think we had Vec out there at the time.
Right.
And then we'd come back out. We'd try again, and then come back out. If that didn't work, then we'd swap medics, and it was just a fucking why don't we just do all this at once?
At least this guy isn't doing what I've seen in systems that didn't have RSI or MFI, but they need a tube because, say the person has trismus or something, right? And the paramedic literally called a doc, asked for orders for ketamine, and the doc was like, "Yeah, give and they left it wide open. Here's your, not give 25 of ketamine, give 250 of ketamine. They just said, give what you think is appropriate. So this paramedic gave all 1,000. So
that's the doctor basically handing you the rope with the noose around the neck and say, here you go. You can hang yourself.
They didn't do that. So the medic does hang a bag of normal saline, opens it about halfway. The EMT connects her to high flow nasal cannula oxygen, then continues the ventilations. The patient is guesstimated about 5'9" and approximately 180 pounds. And the medic now then begins to prep for their intubation attempt.
Here's our vitals going right now.
What was that?
Where's our vitals going? Specifically blood pressure. Where's that at right now?
The last one they took was 95/51.
Do they take another one before the attempt?
Of course not.
Ah, fuck.
Why would
61, 62?
Well, that half open bag of normal saline might have bumped it up.
Doing fucking wonders.
Oh.
Right. So they get out their video scope, their 8.0 tube, their stylet, their meds, and of course, like I said,
their big dick.
Their big dick and their etomidate and their sucks.
Excuse me while I whip this out.
Whip this out.
So the etomidate's given. All right. Then approximately a minute later, the sucks is given, followed by an intubation attempt.
Okay.
During the attempt, because the medic is rooting around in the airway, the EMT looks at the monitor and goes, "Yo, we've just lost her heart rate from 89 to now into the high 60s." And so because of this, the medic gets really spooked and pulls the tube, stops the intubation attempt, doesn't even try again. Doesn't even try to put in a king airway.
What?
At this point, they just go right back to ventilating the patient via the NPA. So monitor cycles another blood pressure, returns is 81/45 via the NIBP. Heart rate is 49 now. Sinus Brady with peak T waves. Respiratory rate is being assisted by the EMT. SpO2's fallen to 90% with the BVM. So medics seeing that it's Sinus Brady, they attempt atropine 0.5.
Oh my God.
Due to the bradycardia. However, heart rate continues to drop.
This medic didn't walk around with his head tilted on the side, did he?
Damn!
Wow.
I'm gonna need a minute on that one.
Holy shit.
Woo! Oh man, Ric Flair would approve that one. So medic administers.
I'm sorry, go ahead.
Medic administers atropine 0.5 due to the bradycardia. Heart rate continues to drop even with the atropine. Junctional rhythm develops, soon transitions directly to asystole.
Shock.
I wonder why.
I'm in shock.
Right. With
Not them shocked because it's asystole, so you already lost that opportunity.
Right.
No, I'm just shocked.
We're all shocked, right? We knew this was going to happen from the beginning.
Yeah.
So
Now tell me they tried to paste the asystole. Come on. Give me that.
Look, there's
Might as
things
well
on there's
now.
squiggly lines. Look, we're doing something.
Right, we're doing something. So CPR is initiated by the paramagician while the EMT continues the ventilations because there's still no tube. This continued until the crew reaches the hospital, right? The medic's going to give an epi every time they break for a pulse check. Okay?
So, real quick question.
Yes, sir.
I must have missed it, but what were the sats before the attempt? With just the straight BVM with the with the high flow going along with the BVM.
91%.
Hey, you know what? Let's just keep going.
Bingo.
If we're not going to nasally intubate,
work sometimes.
If we're not going to nasally intubate, hey, guess what? 91%. I'll
good
fucking
enough.
take it.
It's good enough in my book, right?
I'll
Better than
take it.
76, whatever it was.
Yeah, where were we when we got you? Oh, she was down to 70 something. We're at 91. Hey boys, let's keep on rocking. Let's go. Let's dump another neb. Keep going. You know?
Yep. I 100% agree with everything.
Yeah. So if she was,
Hanks,
if you did all that,
to help open things up. I don't know.
right there. Yeah. So I mean, if all your interventions, you know, your decks, your freaking your neb, the bagging, if none of that was working, if she was still 70s, and you have that capability, and like I said, you wanted to be super confident, devil mask paramedic, and you don't want to nasally intubate for whatever reason, then that would be the time when you're like, okay, this is last chance saloon before she fucking dies. She's at 91%. Hey, fuck, keep going. We're good.
Yeah, 100%.
We're good.
You know,
Yeah.
this is the standard call of BLS is working. Stop trying to overcomplicate the situation. This lady was not in a position to be intubated unless it was nasally. Yeah, that's just the way it was. Like, she was not resuscitated to the point where she could handle an RSI. you know, and we'll talk about what you guys, you know, your honest thoughts about one-man RSI, but you know, this is why they don't happen, right? So they arrive at the ER, right? They unload her into the hospital. The hospital staff continues this resuscitation attempt. The hospital attaches the defib pads because the paramedic never does.
You're fucking kidding me.
They're given EPIs, but they're only going off of what they see on the monitor. There's no shocking pads. There's nothing, right? Intubation is successful at the ER. EPIs continued. And the hospital staff goes ahead and also gives bicarb and calcium gluconate. Ultimately,
I was going to say, well, we know it wasn't Emily.
Right. Ultimately,
bicarb out of here.
Yeah, gotta get that, but get out of there. Ultimately, they will actually regain pulses in the ER.
And I hope she regains her fucking phone call to a lawyer.
Right. And they're going to admit her to the ICU. In the ICU, they treat for a serum potassium of 6.2, hyper K, fluid retention, and treat with dialysis along with some other types of meds. And she goes home. So one of the things that
and probably sent a big old box of cookies and a thank you note to the fucking EMS.
Oh my God. If she did, like,
because they don't know.
Right. More power to
They're ignorant.
Right.
Dude, patients are ignorant. They don't know that they're being treated like shit.
Oh, yep.
They really don't. Because if they did, I mean, I'm not going to make a fire department joke, but I think I just did. So, but there are people out there who we know who, you know, have their heads tilted to the side and get away with it.
Yep. Yeah.
You know, everybody has their version of that individual.
Yep.
If not more than one.
Yeah.
And because the public doesn't know.
And that's the scary part.
Yeah.
Yep.
You know, and one of the things that I think really needs to be focused in on this particular call is the fact that, like, there were bits and pieces of history that you could have gotten, right, before she went down the tubes that wasn't ever gathered, you know? Like, the hospital puts together the fact that she's hyper K because she hasn't gone to, she's got a serum potassium for 6.2, but remember, she's also been sick and feeling like shit for 5 or 6 days. She didn't go to dialysis the previous week. Hence why she's got fluid retention. Hence why she's got potassium up the ass. Hence why her peak T waves are there. Like, you know, there's fluid in her lungs. Like, there's fluid everywhere. The little bit of Lasix ain't going to help her.
It's what happens when you don't go to dialysis.
That's exactly what happens when you have a patient with kidney failure on dialysis that doesn't go. Right? And not like this would have been treatable, on the paramedics' watch. Like, they're going to give, this, that, the other thing. They might give bicarb. They might give calcium chloride. They might give albuterol or something like that. But that's not going to lower that potassium any bit. They need insulin. They need, the calcium gluconate. They need that kind of stuff at the ER and at the hospital. But
it's like what Emily, said way back when we did a dialysis episode, and so they're full of fluid, but it's just not where it's supposed to be. So
right.
maybe some fluid would be in order here. Might get that pressure up. Hey, guess what? It might get it up to where you can do your single man fucking RSLA.
Right. Because ultimately, what are they going to do? They're going to take all that fluid off anyway.
Right.
Right. And it's something that you might have to chance, right? Play that devil's advocate. Okay, well, if I give fluid here, it might bump the blood pressure, but if I give it, maybe it's also going to drop in their lungs. I don't know. Or it could go, to their left pinky toe. Who knows?
Well, yeah, but like you said, when somebody doesn't do dialysis, the fluid's all in there, but it's just not in the right spot. So technically they're fluid depleted. I mean, they don't have it where it's supposed to be.
Right.
So yeah, you go throwing it in there, you might actually fix some problems.
Right.
You know,
So
temporarily. I mean, I'm saying just sit there and fucking run 3 liters into them, but yeah, get them something.
So what do you guys think overall? How did this call go in the grand scheme of things?
To worse.
I would be curious to know if they went the other way, what the other medic would have done.
You know, that is
if they went the right way.
A damn good thought. Like the one that we'll never know, but really interesting. Like, yeah, what one paramedic would do to the other.
Now, did that system have single provider RSI as well?
That I don't know. That I don't know.
I was going to say, because I mean, that might have changed the whole dynamic,
Yeah.
Or maybe they would have had access to a second medic,
right?
On the way in. Who knows?
Yeah.
So,
and I think
the hospital's closer.
Right. And I think it is, good to mention, we do it a lot, but that whole concept of don't forget that we still have old skills like nasal intubation, right?
Yeah.
Where like you and I have fallen into the trap of, oh man, I could have done that.
We should have done that.
We should have done that. Damn it. I didn't even
I could have walked into that hospital like a fucking god.
Right.
If I would remember to do that.
Here I'm walking pelvis first, wiggling,
That's right.
the freaking helicopter going.
Yep. The fucking doors open up. They go, what the fuck is that coming in? It looks like a dick. Oh, there he comes 5 minutes later. That's right. That's me, baby. I nasally intubated.
Even the older skill of sometimes BLS works. BLS airways are working.
Bingo.
Right.
Let it go.
Yeah.
Like we were just having a little Facebook thing on it. How about BLS for ALS?
Yeah, dude.
We need to do that. We really do.
It is in the works. It's coming.
Yeah.
But yeah, no, I agree. Like we've done calls on this show where the paramedic, all they needed to do was focus on BLS skills, and they would have had a positive outcome. And, I think a lot of times that, the paramedics get thrown all of these cool bags of tricks, and they think that's the only thing that they can use to save and make things better. And it's just not the case.
Every time I get a new medic or something driving me, I always tell them, I was like, listen, we are terrible when it comes to BLS stuff. We get all these things, and we forget that sometimes our BLS partners are the important, chain. And we just forget, like, hey, when I go to a call, I will usually, if I have a strong BLS partner, I'll let them start their BLS assessments in the house. And when, I hear those, magic words like, hey, this sounds like a ALS moment, I'll intervene and start doing my ALS stuff. But otherwise, I'll let them do their BLS thing until I hear those, those trigger words, then I'll step in. But because we're terrible at BLS assessments. We really are.
Yep.
So I'll let them do their BLS thing until I need to step in.
Agreed.
That's how I do my thing.
So I know we kind of talked and alluded about how bad one-man RSI is. I think it's personally super dangerous.
It's so bad.
It's so bad.
It's so bad it should be in detention.
You want me bad?
Jump up and down.
There's been systems, in our area that have wanted to try it, and the overall overall medical directors for the regions and stuff are like, yeah, no, that's not happening. And I don't agree with the region all that often, but I agree wholeheartedly that I think one-man RSI is dangerous. It is just flat out dangerous. Think about 5 of the worst paramedics that we all know, and they're the ones that, would be like, I'm going to RSI this patient by myself. And if you think that they could, then it's a great idea. But if you think that that it's going to turn out like this, it's probably not a good idea. I don't understand.
Start marking their ambulance with kills.
Seriously. So talking
little X's,
right? Yeah, little X's, right?
Talking about kills. Why is it a perpetual cycle that paramedics keep going to automate and sucks?
Why do you think?
It's easy to dose.
Easy math.
Beyond easy math. Is there a second reason other than it's easy to dose? Because
revert to training.
It's short. I think it's the short onset and half-life as well too. Because when you give that rock, you own that airway for like,
30 minutes an hour ish.
And that's the thing. So I mean, just to kind of go down that hole, because that's exactly where I was going to go. Like, I know for training wise, when people come out of paramedic school like we did, when you're in class, it's always accommodate sucks, sucks.
Right.
Don't even talk about ketamine. Then you get out and you start, hey, you know what? I have all these options. I'm still going to do accommodate sucks, or in my case, I prefer to go ketamine, and then sucks and all that good shit. But it wasn't until like, actually Emily and I had a conversation, and it was the reason I wouldn't go to the Rock. It was for that reason. I didn't want to own their airway for the next hour, whatever. It was, I didn't want to turn them over to the hospital still being paralyzed. And she was like, who fucking cares?
Right.
Fucking just do it. And I'm like, yeah, you're right. Who the fuck cares? I should just do that.
Well,
so after that, it was like, yeah, it was an easy fix,
I can tell you from experience, you turn a patient over to certain doctors in certain regions with that rock on board, they get a little pissed off at you.
But at the same
Well, then you
point,
can just open up your protocol and say, here you go. Hey, have a good day.
So it's funny that you bring that up with the protocols, because I don't know, anyone else, like, Wyoming, someone listening in Wyoming or Montana or,
Michigan,
West Virginia or Michigan or wherever the fuck you're listening from. I don't know what you could do. So it might say, yeah, you got VEC, you got rock, you got, sucks, you got all these different choices, right? And you can use them willy-nilly, whichever patient you want. Just run with it. Here, where we all practice, you are forced to use sucks first unless there's a indicating contradiction, or contraindication. I'll buzz myself for that one.
Sucks has a million of them. Sucks is
and there's a million of them.
Terrible drug.
So, but we're taught in RSI classes, accommodate and sucks. Oh yeah, we don't ever use rock and VEC. We don't even carry rock and VEC. You're taught accommodate and sucks. You're taught that everybody is more or less, 220 pounds, so that the dosing is 100 and 100, right? You're taught the easy, stupid ways to do an RSI. So that's, Gerard, you say it all the time. What you learn early, you never forget. Like,
law of primacy. Yep.
It's built into the problem, and the cycle is built into how it's taught and how it's defined in the protocols, at least in our area. I think, and I think a lot of it at the protocol level is the doctors don't trust us to do things the correct way. So they want that short offload time, because they're like, yeah, if they fuck the airway because our standard, first pass intubation rate is 26%, I wonder why they don't want us rooting around in a paralyzed airway for 45 minutes. Maybe if we get better and show them that we don't suck as much, we wouldn't have these problems.
It's like they tell you when you intubate, you got to be in like 30 seconds, and not in 30 seconds, but you oxygenate a patient correctly, and you have that, high flow oxygen going there, you can be in there for quite a bit of time before that patient desats on you. You can be in there and take your time and do it properly.
Right.
It's not as scary as people make it out to be, an intubated patient.
It really
isn't. Smoothly.
It really isn't. So the one thing that I pulled up that I wanted to talk about was sucks and hyper K. Why we don't actually give sucks in hyper K, right? So succinylcholine is a relative contraindication for patients with increased serum potassium. So in normal healthy patients, so, someone that's, having like a cardiac problem or, a trauma problem, and we need to RSI them, right? That that sucks is going to increase serum potassium by anywhere from 0.5 to 1 milliequivalent per liter. So not a whole lot, right? But now if you're, putting that to a sick patient who is on dialysis or has burns or something like that, which has a already high serum potassium, that is now going to jump way up high, well past 5, well past 6. And now you're starting to have all of those, altered mental status, the shortness of breath, the chest pains, the palpitations, along with all of the cardiac changes. This is why they don't want you to use it in these types of things, Remember that SUX is that depolarizing neuromuscular blocker, right? So it causes those fasciculations. So every time that you push SUX, it's causing a fasciculation in those muscle fibers and causing a leaking of potassium. This is why that serum potassium increases. If you do it in someone that already has a high potassium, you're fucking them, right? Yep. People should understand that. This is why we don't want this. This is why it comes with the laundry list of, this is not when to use it, those contraindications, We talked about it in the last episode that we talked about Hyper K. I don't remember if it was on the free or the Patreon, but the cardiac changes. But you can address these if you want, but you're going to see different levels of cardiac changes, right? You might start with a depressed or
T waves.
Thank you. ST segment, right? You might see those peak T waves.
Pointy T waves, yep.
Right. The PR interval is going to widen. The QRS interval or the QRS duration is going to widen, right? Eventually you lose your P wave, and right about the time that you lose your P wave, your QRS is so wide that you get what's called a sinusoidal wave, which is really cool. I'll have to do one of my...
That sounds yucky.
It sounds like something you pick up at a dive bar.
Let's stop talking about
with a win.
Let's stop talking about Kelly's girlfriends. All right, it's not nice.
Whoa! I don't know if she swung for the other team.
Hey, whoa, hey!
Oh, hey, ho! This is Goose.
But yeah, so there's definitely indications that, you guys can see and measure when you're looking at the cardiac, EKG, to be like, hey, they might be hyperkalemic here. Oh, hey, they're a dialysis patient. They've missed 5 days of dialysis, their last 3 appointments or whatever. You got to look at the history.
Use SUX.
And then you go ahead and use SUX, and then you kill them.
Yeah.
It's yeah. So, anything else to add to this one, guys, before we wrap it up? I think this one was tough. Like I said, this is a total Patreon episode. However, I thought it was time for a really good juicy call on the free side.
Well, it didn't involve a blender, so
that is.
I guess that's good.
That is good. Or a giant pink dildo.
Well, that's always
this is
fun.
so true.
or hills and oil tankers and all the
or
other
mahogany tables and ceilings.
Right.
Yeah.
All of the other bullshit that happens on that show.
Yeah. Or that fucking, what the hell is the name of that goddamn disease? Oh, shit, I can't even remember.
Was it the one? Was it
the one I talked about?
No. Oh, that was von Clausewitz or whatever. Yeah,
Von Helsing's disease.
Right. Yeah.
Van Helsing's.
Yeah. The vampire slayer disease or whatever it was.
Right. Yeah.
Oh my.
No, the one that we did with Emily there,
Hashimoto's.
Graves, the one that was like Graves, but it wasn't called Graves.
Yes. Yeah, that one was weird.
Yeah, that was a weird one.
That one was weird. Yeah, it was weird.
I'm trying to remember the name of that goddamn disease.
I'll have to go back and listen because I don't even remember.
Apparently, we didn't fucking learn.
Apparently not. Bad us. But yeah, do you have any final thoughts for this one, guys, before I wrap it up?
Just
BLS before ALS. That's
BLS before ALS. Yeah, if your BLS shit's working, simple rule: if it's working, don't fuck with it.
Yeah.
Just let it be.
Yep. If
it starts to look like you're
fix it.
like you're gonna lose it, then you might want to put your hands on that. But no, man, if your BLS airway's doing good, or like I said, if you can remember the nasally intubate, go for it. Fucking A, be a boss. But yeah, if I've got 91% and we're bagging and I'm not seeing any stomach extension, yeah, man, everything's doing good. Shit, but keep going.
Yeah. Yep. Agreed.
Yeah.
Well, it was called Basedow's disease, by the way.
Basedow's, that's what it was. Yes.
The Phil Foundation coming through. There you go.
Right.
All right,
he doesn't
guys.
say much, but when he says stuff, he's right there with it.
That's
I know,
right.
right?
He is short and to the point, and I thank you for it.
Damn
That's
Skippy.
right.
Well, guys, thank you very much for joining us on the last episode of this month. Join us for the Patreon every 23rd day of the month. So whatever the 23rd falls on, that's when the Patreon drops. Again,
23rd.
Yeah, it falls on the 23rd. Yep.
Right.
Yeah, they are the wildest and crazy conversations. I edit these down a little bit. I don't edit those at all, which is great. So if you're interested in becoming a salty veteran or what's the other one? I don't even remember. Salty veteran or seasoned provider. That's what it is. I haven't looked at the Patreon in a while.
I was thinking like crusty provider or some shit like that.
No. You will get access to that third monthly podcast. So hit that link down in the description.
That'd be good for you.
or show notes below and sign up. It's dirt cheap. It's like $5 a month. So for the other extra episodes. So till next time,
what are you gonna do with $5?
I know you're gonna give it to us for entertainment purposes. That's what you're gonna do.
We're gonna sink it in more equipment to make things better.
Hold on.
Right?
Phil Foundation, you have been a Patreon since we started the Patreon page. Is it worthwhile?
Oh, it's worth it.
Yeah, I mean,
it's worth it.
It's so worth it. But yeah, that's my shameless plug for today. Stay safe, guys. Till next time.
Phil Donuts.
Ooh.
Just because he chimed in. It was Johnny on the spot. I'm sorry, it was Phil on the spot.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.